Hello, my name is Jamie Buchanan. I'm an orthopaedic surgeon here at the Conquest Hospital in Hastings. I've been involved in upper limb, shoulder and elbow surgery for the best part of 20 years. And today we're going to talk a bit about shoulder pain, particularly in relation to the rotator cuff. This is a model of a right shoulder. You're effectively looking at my right shoulder from the front. This is the collarbone, known as the clavicle. This is the upper part of the arm bone, known as the humerus, and this here is the scapula or shoulder blade. The ball and socket joint is a ball at the top end of the humerus which articulates with the glenoid or the socket, which is part of the shoulder blade or scapula. On the outside there's a very big muscle which we call deltoid, and if you peel away deltoid there's a space underneath where the muscles of the rotator cuff sit. These muscles help keep the ball snugged onto the socket. There are 4 big muscles in total, and they need to function properly in order to allow the big muscle deltoid on the outside to work most advantageously. You will see if you look at the side here that the muscles of the rotator cuff slide underneath this arch, which is known as the acromion. The muscles I'm mainly going to be talking about is a muscle at the top here called the supraspinatus muscle, and then at the back here is the infraspinatus muscle, and there are others around here which help keep the ball centred in the middle of a very flat socket. As we get a bit older, the muscles start to scuff and start to become painful as they rub. Part of the rubbing is not just on the bone, but this ligament here, which is made of rubber in your youth, gets a bit older. As time goes by, it gets a bit stiffer and it starts to impinge or encroach on the top surface of the tendons, somewhat restricting their movement. One of the common questions asked is, have I got tendinitis, bursitis or subacromial impingement? To be honest with you, they're all part and parcel of one and the same process. I think the term rotator cuff related shoulder pain is an umbrella term which covers all the problems. In essence, the tendons become thickened and they become irritated, they may be scuffed and they may even be torn. And as a result of that, one has pain abducting the arm, reaching behind your back, trying to put your hand in a jacket, pulling up your trousers. And you can see that when the arm is hanging down, it tends to open up the space. But at night, when you're lying horizontally, there's a tendency for the humeral head to ride up, which is why it's so uncomfortable at night as you try to put up the duvet, reach for the alarm clock, the bedside light, all that sort of thing. As this is really part of the ageing process, we must ask ourselves, is there a way to try and make this better? Actually, 80% of people respond very well to non-surgical treatment. That is treatment from your physiotherapist, who will help strengthen the muscles of the rotator cuff, gradually increasing the load that they're able to bear, which helps keep the ball snugged, more centred on the socket without the need to resort for surgery. You may wonder if special investigations such as X-ray, ultrasound or MRI scan are required in the first instance. This is not always the case, because it isn't unknown to X-ray, MRI or ultrasound the other shoulder which may be asymptomatic, and we find that actually the age-related changes are no different from that which you find in your symptomatic shoulder. So in the first instance, your therapist will quite often be very happy to make the diagnosis and start the appropriate treatment without the need for these investigations. If with time you fail to improve, and we need to consider taking it further, then an X-ray, an MRI or an ultrasound scan may become increasingly appropriate. In summary, therefore, rotator cuff related shoulder pain is in a large part an age-related problem. With 80% of people improving with careful guidance of a therapist, this is clearly the best way forward. Do not expect instant results. But under the guidance of your therapist, one would hope in the first 2 or 3 months we would see an improvement in pain, strength and range of movement. If things fail to improve, your therapist will probably make a referral to a shoulder surgeon such as myself, and that surgeon may or may not recommend taking this further. Take-home points. There are many structures involved in rotator cuff related shoulder pain, which can be difficult to pinpoint the exact cause and mechanism of the pain. Recent evidence guides us towards the fact that tendon and the bursa may be the main culprit and the focus of your rehabilitation. 80% of patients respond to non-surgical management. The REACH product has been designed to help you manage your condition. You are required to be an active participant and expect 6 to 12 weeks before you start to feel benefits from this programme. If you fail to make those expected gains, you must of course discuss this with your rehabilitation team.